Welcome to Roadmap to Residency. In this video, we are tackling thyroid and endocrine surgery for the United States Medical Licensing Examination Step 2. This is not a full lecture. We are focusing on the high-yield question stems and test-taking strategies you will see on exam day. Before watching, make sure you have reviewed the endocrine and surgery sections in First Aid and your question bank. This video will teach you how to apply that knowledge when you see these questions on the test. Let us dive in. Here is what we are covering today. First, we will learn to recognize the classic question stems for thyroid nodules, thyroidectomy indications, hyperparathyroidism, and adrenal masses. Second, we will work through specific test-taking strategies for each topic so you know exactly how to approach these questions. Third, we will master the next best step format, which is how the boards love to test surgical decision-making. Remember, review your foundational resources first. This video is about strategy, not memorizing every detail. This is Strategy 1, and it is one of the highest yield concepts for thyroid questions. When you see a thyroid nodule on the exam, the first branch point is always the thyroid-stimulating hormone level. If it is suppressed, you order a thyroid scan to see if the nodule is hot or cold. A hot nodule takes up iodine and is almost always benign, usually a toxic adenoma. Treatment is radioactive iodine or lobectomy. A cold nodule does not take up iodine and needs a fine-needle aspiration biopsy because it could be cancer. If the thyroid-stimulating hormone is normal, skip the scan entirely and go straight to ultrasound and fine-needle aspiration. The boards test this algorithm over and over. Strategy 2 covers thyroidectomy indications. The absolute indications include confirmed thyroid cancer on biopsy, compressive symptoms like trouble swallowing or breathing from a large goiter, and Graves' disease that has failed medical therapy or is causing significant eye disease. The relative indications are where the boards get tricky. If a fine needle aspiration comes back as indeterminate, meaning Bethesda category 3 or 4, a diagnostic lobectomy may be needed. Large nodules over 4 centimeters, substernal goiter extending into the chest, and cosmetic concerns are also relative indications. Know that total thyroidectomy is preferred when cancer is confirmed or disease is bilateral. Let us talk about recognizing the classic question stems. For thyroid nodules, look for a patient with a neck mass and then follow the algorithm. Check thyroid-stimulating hormone first, then decide between a scan or a fine needle aspiration. For hyperparathyroidism, the classic presentation is elevated calcium with elevated parathyroid hormone, and the patient has stones, bones, groans, and psychiatric overtones. For adrenal incidentalomas, the boards will give you a mass found on imaging done for another reason, and the first step is always to check if it is making hormones. Here is our first practice question. Read this carefully. A 45-year-old woman has a thyroid nodule, normal thyroid stimulating hormone, and suspicious ultrasound features including microcalcifications and a solid hypoechoic appearance. They are asking for the next best step. Take a moment to think about this before we go to the answer. Let us walk through this answer step by step. Step 1. Spot the pattern. Normal thyroid stimulating hormone plus suspicious ultrasound features. That tells you the scan is not needed and you need tissue. Step 2. Apply the rule. When thyroid-stimulating hormone is normal and the nodule looks suspicious, fine needle aspiration biopsy is always the next best step. Do not jump to surgery without pathology. Step 3. Eliminate wrong answers. Observation is wrong because those features are concerning. Lobectomy is premature without a biopsy. A radioactive iodine scan is only for when thyroid-stimulating hormone is suppressed. The correct answer is B, fine needle aspiration biopsy. Here is our second practice question. This one is about hyperparathyroidism. We have a 55-year-old man with recurrent kidney stones, elevated calcium, low phosphorus, and an elevated parathyroid hormone. Think about what the next step should be before we move on. Let us break this one down. The question gives you the classic triad of primary hyperparathyroidism: elevated calcium, low phosphorus, elevated parathyroid hormone, plus symptomatic disease with kidney stones. This patient meets surgical criteria and will ultimately need a parathyroidectomy. However, the question asks for the next step, not the definitive treatment. Before sending someone to surgery, you need localization imaging with a sestamibi parathyroid scan to identify which gland is abnormal. Starting a bisphosphonate does not treat the underlying disease. Repeating the calcium is unnecessary when the diagnosis is already clear. The correct answer is B. Obtain a sestamibi parathyroid scan. Now let us review adrenal mass management. This is extremely high yield. Every adrenal incidentaloma, no matter how benign it looks on imaging, needs a functional workup. That means plasma-free metanephrines to rule out pheochromocytoma, an overnight dexamethasone suppression test to rule out cortisol excess, and if the patient has high blood pressure, check an aldosterone to renin ratio. Any functional tumor needs surgery regardless of size. For non-functional tumors, surgery is indicated when the mass is larger than 4 centimeters because of increased cancer risk, or when imaging features look suspicious. And here is a board favorite. If the mass is a pheochromocytoma, you must start alpha blockade with phenoxybenzamine before any surgical intervention. Never operate on an unblocked pheochromocytoma. Here is practice question 3. An adrenal mass is found incidentally on a scan. It is 3 centimeters with low Hounsfield units, which suggests a lipid-rich adenoma. The patient is asymptomatic with normal blood pressure. Think about what the next step should be. Walking through this answer, spot the pattern first. This is an incidentally found adrenal mass, which makes it an adrenal incidentaloma. Even though the imaging looks benign with low Hounsfield units, you cannot skip the functional workup. The key distinction is that imaging tells you about anatomy, but biochemistry tells you about function. Surgery would be premature without knowing if this mass is making hormones. Repeat imaging alone misses functional tumors. A positron emission tomography scan is not the first-line test for a benign-appearing mass. The correct answer is C, biochemical workup for hormone excess. Here is a critical test-taking pearl about hyperparathyroidism. Know the surgical criteria cold. Surgery is indicated for symptomatic patients, including those with kidney stones, osteoporosis, or neuromuscular symptoms. It is also indicated for asymptomatic patients who are under 50, have calcium more than 1 milligram per deciliter above normal, have reduced kidney function, or have low bone density. The biggest board trap is familial hypocalciuric hypocalcemia, which looks like hyperparathyroidism on labs, but has a low urine calcium excretion. Always check a 24-hour urine calcium before recommending surgery. Also, do not confuse primary hyperparathyroidism, where calcium is high, with secondary hyperparathyroidism from chronic kidney disease, where calcium is actually low. That wraps up our thyroid and endocrine surgery review. Remember, review the endocrine and surgery chapters in first aid and your question bank. Pathoma is great for the underlying pathology. Focus on the algorithms and decision trees rather than memorizing every detail. For expert one-on-one tutoring and residency advising, visit roadmaptoresidency.com. If this video helped you, please like and subscribe so we can keep making high-yield board review content. Good luck on your exam, and we will see you in the next video.